Hi, my name is Ed Shahady, and we're here at the Cardiometabolic Risk Summit in Nevada, and I have with me Dr. Gluckman. Dr. Gluckman is a cardiologist. He's going to be speaking in a few minutes on some controversies in PCSK9. Also, he's going to be talking on quality measures in medicine, and he's in Portland, Oregon. Dr. Gluckman, what are some of the highlights you're going to say regarding quality measures?
Well, I think this afternoon we're going to be talking about heart failure and recognizing the importance of adherence to guidelines. We know that several proven long-standing therapies remain underutilized in patients in general. More broadly, we're going to be talking about dividing heart failure into those that have reduced ejection fraction and those that have preserved ejection fraction, with a much stronger evidence base in those that have heart failure with reduced ejection fraction, and the importance of treating a lot of comorbid conditions to reduce morbidity and mortality with heart failure with preserved ejection fraction.
But one thing frustrating about guidelines is they change always. New evidence comes out.
Yeah. I think it's frustrating for us as providers of care, but it's equally frustrating for patients as well, understanding why all of a sudden what was one thing one week could change the next week. I also think on a national scale we have a challenge, at least with the American College of Cardiology and the American Heart Association, of updating guidelines in a timely fashion and distilling guidelines down in an algorithmic way that allows the end user, both patients and providers, to understand, what am I supposed to do?
Sure. Heart failure, high output, low output. It seemed like you said there was more evidence, for low output?
For people who have a reduced ejection fraction, the evidence base is stronger in support of certain pharmacotherapies, such as ACE inhibitors, angiotensin receptor blockers, beta blockers. We're going to be talking about two novel agents that have been approved for heart failure with reduced ejection fraction, showing incremental benefit on a background of standard therapy. So it's exciting because for at least a decade, we really didn't have any new advances in that patient population. Heart failure with preserved ejection fraction is still a very frustrating group because it represents at least 50% of our heart failure population, with really not a lot of great inroads with targeted therapies shown to improve heart outcomes.
Okay, so that sounds very fascinating. Go to PCSK9s. You know, that's been last year, 2 of them released. A lot of concerns about the cost, but they are effective. So, you know, I think you and Dr. Block are going to be talking in maybe a debate. Could you give us a little bit of highlight of what's going to go on there?
Sure. I mean, I think it's always fun to engender some contentious discussion about these types of things. So again, it's similar to the heart failure arena. In lipid management, we've had rather disappointment in established therapies like niacin, but we've also had the advance of PCSK9 inhibitors and perhaps other novel approaches to lowering, in particular, LDL cholesterol. We're going to be focusing on those, the evidence base that we have, and highlighting the fact that what a lot of us are waiting for are the outcomes trials that are due out either late this year or more likely next year in 2017 that will provide incremental information to help us understand, do these, at least in patients with atherosclerotic cardiovascular disease, and a couple of trials looking at even high-risk primary prevention, do they add to what we already know are effective in statins? I do think it's also important to call out, we've seen this in the cardiovascular literature and in more broad literature, is existing therapies in statins are underutilized today and are underutilized in the intensity that's recommended by National Lipid Association, the American College of Cardiology, and American Heart Association. So I think coming home to what we have a firm evidence base for 2 decades, and then talking about who are those patients. Dr. Block's going to be talking about a familial hypercholesterolemia patient. I'm going to be talking about a secondary prevention patient who has atherosclerotic cardiovascular disease. And who are those patients that really derive the greatest benefit?
Well, say I'm a stubborn clinician and I want evidence. And I do have evidence for statins, and now even adding ezetimibe, I've got some evidence in a certain cohort of patients. I don't have outcome for PCSK9, so I don't want to use it. How would you respond to that?
Yeah, and I think we're not going to have any hard outcomes trial data for the familial hypercholesterolemia patient, but we know that from observational data and from some randomized trials, that is a particularly vulnerable and high-risk patient population. So we were having discussion about that. For most of us, the use of PCSK9 inhibitors has been more firmly consolidated in that patient population. I think the atherosclerotic cardiovascular disease secondary prevention patient population, That's where we're going to have a lot more data in 2017 and 2018 that will help inform us. The frustrating thing is even that outcomes data may not help to eradicate all debate because there will still be issues about, is this cost effective? Sure. Even if it's effective and it improves heart outcomes and is safe, what is the cost effectiveness of that? And that gets into issues of absolute reduction, numbers needed to treat, to hopefully help with stubborn clinicians, but non-stubborn clinicians to help understand.
Absolutely.
And we should be holding ourselves to that evidence base overall.
You said cost effectiveness. Cost is a big issue with PCSK9s. Are you lucky in getting insurance companies to pay for that for some of your patients?
So I think it's a challenge today, both from the payers and from the patients overall. As we were discussing just a few minutes ago, patients are increasingly facing high deductible health plans, a greater degree of co-insurance or co-payment for their health care, including their drug spend. And so this is an ongoing challenge that we have overall. I think what many of our local payers have asked us is to have very good documentation about the rationale for addition or request for a PCSK9 inhibitor, but even in circumstances where it's paid for, the actual cost that it's being paid for that patient may not be affordable for that given patient. So we've had to look to foundations and other creative ways to help cover those drugs.
Dr. Gluckman, thank you very much. Very excited and I look forward to hearing you today.
It's absolutely my pleasure. Happy to be here. Thank you.